Hello, and welcome to the Center for Health Design's Evidence-Based Design Journal Club. Thank you for joining us. Hi, I'm Michael Compton. I'm one of your co-hosts for today's session. As a bit of an introduction, I'm a healthcare architect at Gresham Smith & Partners in our Jacksonville office, although our firm is based in Nashville, Tennessee. The purpose of the Evidence-Based Design Journal Club is to broaden the design community's knowledge, understanding, and application of built environment research. Continuing education units are available for this webinar from the AIA and from EDAC. To receive credit for your participation, you can download the forms at any time by clicking on the Show My Library icon, which is located on the top toolbar, where the red arrow is pointing. You'll have access to the AIA quiz, the EDAC form, and today's presentation slides. To download a file, click on the green arrow next to the file. When you are finished, click the double right arrow in the top left corner of the media library. The library will close and the slides will refill the empty space. For EDAC credit, complete the verification form and retain it for your records. You will need to submit the form to CASA Worldwide at the time of your renewal. For AIA credit, complete the verification quiz, purchase the CEU management fee for $10 from CHD's store, and submit the verification form to Shannon Reckline. She'll upload the credits to your AIA account. You'll find Shannon's email address included in the form. I'd like to take a moment to review how to use the chat feature so that you can ask questions or submit comments on what you hear today. As shown on the slide, you just type into the chat box where the red arrow is pointing. Please be sure to chat your questions to all so that all the attendees in today's call are able to see your message. If you're having any technical difficulties, please type your issue to moderator in a private conversation and we will see how we can help. Please let me introduce Peter Sharp, my co-host for today, who will be leading today's discussion with Dr. Craig Zimring and Megan Denham. Peter Sharp is Vice President of Irwin P. Sharp & Associates, a research and marketing consulting firm specializing in new product development and technology transfer. The firm has wide experience in building and construction materials and architectural engineering services. They are actively involved in research and clinical trials related to antibacterial materials for contact surfaces, potable water distribution, and HVAC systems. Peter is on the Center for Health Design's EDAC Advisory Council. Peter, would you please introduce today's guest, authors?
Thank you, Michael. And again, welcome everybody. I'm excited to participate in today's discussion around this special supplement of the HERD journal that really focused on developing a better understanding of the role of facilities design in the acquisition and prevention of healthcare-associated infections. It was supported by the Agency for Healthcare Research and Quality, AHRQ, sometimes referred to as ARC. There are about a dozen articles in the supplement covering perspectives from designers, from design researchers, doctors, nurses, architects, and public policy influencers. On page 27 of the journal, Dr. Craig Zimring and Megan Denham have highlighted some key interventions, conclusions, and research needs that came out of the project. And they're joining us today to provide some additional insight and depth to the project, the research, and to the process. Megan is research faculty at Georgia Tech's Centigrade Design Lab, which supports better healthcare at lower costs through innovative design. Her research focuses on evidence-based design to improve healthcare facilities, to reduce the risk of healthcare-acquired infections through the environment, and promote patient and family-centered care. Megan has authored multiple peer-reviewed journal articles, and she contributed to or was the lead on about half of the articles in the HERD journal supplement we're covering today. Dr. Zimring is an environmental psychologist and professor of architecture at Georgia Institute in Technology. He established and is the director of the Centigrade Design Lab. He serves on the board of the Center for Health Design and has directed research with the Military Health System, Healthcare, NIH, Robert Wood Johnson Foundation, Phillips Lighting, Hill-Rom, and many others. He has over 85 publications in the scholarly and professional press and has won 10 awards in his research. Thank you both for joining us today.
Peter, thank you so much for the introduction, Michael, and thank you so much for the Center for Health Design for this opportunity to talk to this wonderful webinar group this afternoon here in Atlanta anyway. So, Peter, do you want to?
I was going to make a quick introduction, then let you and Megan take over.
Okay. Okay, great.
The overall objective of the research was to conduct a review of current evidence evaluating the role of the built environment in the transmission of healthcare-associated infections. It covers the role of the environment and the role of the pathogen. They developed a conceptual framework. There's a discussion of methods and implications of practice. There was a discussion early on how the research involved multiple members from multiple disciplines. Craig, I'm wondering if you could take a couple of minutes to introduce some of your team members and how they were integral to this project.
That would be great, and thanks again. Sorry to step on your line here, but we're very excited to be here this afternoon. So this was a collaborative effort between AHRQ, ARC, and particularly Kendall Hall, who was our project officer, but also an integral member of the team. Many people on this call may know her. She's a physician and an architect. RTI International, which is a group in Washington and Raleigh and other places. And we had the opportunity there to work with Doug Kameraw, who's a physician focusing on public health, Nancy Levesty, who's a public health, public policy focused person, and Emily Richmond, another public health expert. At the Emory School of Medicine, we had a chance to work with Jay Steinberg, who's a hospital epidemiologist and senior member of the faculty there in the Department of Infectious Disease, Jesse Jacob, who's a hospital epidemiologist, but also Amy Allison. And Amy is their medical librarian at Emory and was critical in helping us get this information. At Georgia Tech, we had the authors that you see here, which includes Megan, who you've met, Alta Casali, who's an architect, Ellen Du, who's an architect, and David Cowan, who's a health systems engineer. And I just wanted to quickly point out on this list that we have multiple disciplines as shown on the screen, but this really represents both several kinds of practice, but also several kinds of science. So in practice, it's of course architecture, medicine or epidemiology, health systems, but in science, it is the science of infectious disease. That is how bacteria grow, are prevented, and are eradicated, but it is also the science of healthcare delivery, how you change behavior so that real people in real settings don't get infected. And for those of you who have the opportunity to see the whole issue, and one thing I should acknowledge is that the sponsorship of this issue by ARC means that it's available for free and is in the public domain. And I think the Center for Health Design will make that available to participants who want it. But for those of you who want to suggest it to colleagues, the entire issue is available both from the HERD website and from the Centigrade website. And as we go forward, we'll point to that.
Thank you. Megan, in reading through this, noteworthy to me was the scope of the project, any project of this nature, and the comprehensiveness of your review. I'm wondering maybe if you could touch base on the approach the group took and involved in it?
Sure. Well, I just kind of jumped in head first and hoped that there was plenty of water in the pool. So the collecting the data and doing the preliminary lit search was actually done before I started at Georgia Tech. Craig can kind of talk about how they came up with the terms that they did for the first part.
Okay, that's great. So what we did was our team worked with the medical librarian Amy Allison at Emory and others to come up with a list of keywords. And as you know, Peter, there's the National Library of Medicine has come up with medical subject headings called mesh headings that allow you to search effectively. So we used a series of mesh terms which are included in the chapter. In Chapter 1, we then did a series of searches which resulted in 3,800 articles which focused on the domain that we're focusing on, which in this case is inpatient hospitals in the U.S., looking at articles that link some kind of measurement of the built environment to some kind of measurement of outcomes. So, and we searched for specific places, healthcare facilities generally, but also critical care units and emergency departments and so on, and a wide range of outcomes, as well as looking at specific features of the built environment like carpeting and amenities and other things. So this resulted in 3,800 articles, and this is what Megan faced when she, when we enticed her across the street from Emory to Georgia Tech, and we said, here we have a large team, we have 3,800 articles, we have to make sense of this. Now, Megan, you help us do that.
Yeah, so one of the challenges up front was figuring out how we wanted to, what data we wanted to include, just simply what counts as built environment. And so how do we want to include only U.S. hospitals, or are there additional hospitals that are similar styles to include in the study? And then it was also making sure that as we began to review the data that we were all looking at it in a similar way and rating the articles in a similar way. So we used an approach to summarizing articles called PICO, which stands for
Patients. It's an acronym. It means patients, interventions, comparison groups, and outcomes. So it is looking at those four aspects, and that's a well-established framework for medicine and epidemiology. So we developed, Megan and her team developed PICO tables for each of these 782 articles that made the first cut based on things like they're in English and they are appropriate for our study.
Yeah, we had to make sure that we had good inter-rater reliability. So we had several exercises where we all had to read and rate the same articles, just so that we could come to a consensus on what counted as a good quality article.
Was it important that the different articles included multiple components of the PICO group?
Yes. So, for example, all four of those PICO issues had to be, first of all, clear in the article. But second is that there were many articles, for example, which talked about infection but had no built environment component, and those were excluded because we're talking about building relationships between some aspect of the built environment and some outcome. And I think we're going to talk for a few minutes about endpoints, but it had to include all of those things in these PICO tables. I should just point out that in the issue we have provided evidence tables for all of the 203 studies, and those evidence tables have those PICO elements in them, somewhat further evolved. So for the audience who wants to look at that, it is available in the report, in the issue.
And one of the challenges as we increasingly try to draw parallels between evidence-based medicine and evidence-based design is that a lot of the tools that we use to evaluate quality of medical evidence it just doesn't apply to, or it's really impossible to do within the framework of the environment. So we did modify some rubrics for grading evidence that's available through ARC so that it better supported the works that we were reading.
And part of this also is just what I talked about a minute ago, is that it's not only the collision between practice and science, but it's a collision between two kinds of science. So the medical science is looking for very specific cause and effects, but the science of the ergonomic science, the science of healthcare delivery, is about how you can make effect in the real world settings that often have bundles of interventions and bundles of outcomes. So those themselves drove to different ideas about rigor and quality, in addition to the difference between what an architect or a physician might be interested in.
Okay, I'm sure we're going to get back to a discussion on bundles a little more this morning. I should note that the way your team started segmenting this and the way the issue was designed was to try to look at it in terms of transmission, in terms of contact transmissions, air transmissions, and water transmissions, and we'll get to that in a little more detail as well. But what struck me as very interesting was the way you developed what you call this chain of transmission model, because it takes into account how transmission of infections are potentially directly transmitted. For example, when a colonized or infected patient or caregiver or family touches one another, and indirectly when over the course of normal patient care, infected or colonized hosts, as you call them, might infect a surface, which could then become a reservoir for infectious bacteria, and then that surface could become a potential source of transmission. And that's just in the contact stage. You develop the same type of thing in air and water transmission. I'm wondering if Megan or Craig, if you want to tell us about this conceptual framework of the project.
Yeah, so each of us who come from different disciplines and backgrounds all speak a different language. And so this served as our conceptual framework. It was sort of our Rosetta Stone of how do we conceptualize the movement of pathogens throughout the healthcare facility. And so this represents all of the possible ways that pathogens and bacteria can get into the hospital environment. It can come in through an external source, which is soil or something that's in the air, but it can also come in on people, and that can be someone who is sick. But it can also be just natural pathogens that live and exist in our own bodies, that if they get outside of us and either get someone who's immunocompromised, or if we then inhale it, we can get sick from what's in our own body. And so this is just how we think about how do pathogens move through the environment.
This also points out a couple of other things. One is that, as you suggested, Peter, we've organized this around contact. So there's many pathogens that if you touch someone who's compromised, touch a surface, someone else touches that surface and then touches someone who has who's susceptible to infection. It is that touch, and that chain can be interrupted at multiple points in the process. And things like MRSA which is an antibiotic-resistant staph infection, is transmitted that way. TB, for example, is transmitted through airborne paths. Legionnaire's disease is waterborne. So this is a way that the infectious control community thinks both about how to categorize pathogens, but also how you can interrupt this chain. And the hope is that if you can interrupt some or all of these links in the chain, you can reduce or eliminate infection. So, and that what this really illustrates is that you can stop it at any step. So if you have an infected host, you could prevent them from coming into the hospital, or you could get rid of infection in them by giving them an antibiotic, or you can change behavior in other ways.
And I note that you talk about how long some of these pathogens exist if they're not killed or disinfected or cleaned. I brought up this next slide, which these blue pentagons are some of the interventions that either you looked at or were discussed. Noteworthy is that some are actual design interventions and some are behavioral interventions. Do you want to discuss that a bit?
Yeah. So one of the things that I'm actually really proud of with these articles is the pathogens table that is in the introduction article. When I first started reading through all of these thousands of literature, I literally had giant Post-it notes all around my office to try to remind me what's Legionella, how is it transmitted, where does it live. And so that pathogens table can help to figure out where do they live in the environment, how dangerous are they, how long can they survive. So I encourage you to look at that for reference.
And one comment is that this has been sort of clear to us, which is how, or surprising to us as we work with our team, is that there are some pathogens that can exist for, like C. difficile or others, that can exist for days or weeks on a surface. So many of these are quite persistent, although they vary a great deal.
And the opportunities for intervention are through the environment include disinfecting or filtering out the air with HEPA filters or other biocidal materials. It's cleaning the water, but it's also presenting people with more hand hygiene opportunities, locating sinks in a conspicuous location so that people are more likely to remember, oh, hey, I need to wash my hands. So in that sense, the environment is really important to influence and change behavior.
Go ahead, Peter, and then we can address. I see questions popping up, which is absolutely terrific. We can deal with those in a few minutes as we go about how do we deal with some of these interventions. But let me flip this back to you, Peter.
Okay, and actually one of the questions that just came up, which might be directly involved with what Megan was talking about, was this question about something that's maybe easy to clean. Our infection control staff asked that we order vinyl fabric for all upholstered furniture in patient care areas. Is this selection supported by science, and what other options might there be?
Let me give the general answer to that, and then we can talk about it more specifically. So one thing is, as we talk about the chain of transmission model here, it's worthwhile separating out the notion of surfaces being colonized, which means that there's something on a surface, versus leading to infection. So if we look at carpeting, for example, and you measure carpeting, it is there's often pathogens in the carpeting, but our colleague Jay Steinberg, was the recent president of the Hospital Epidemiology Association, says that you can use carpeting in patient treatment areas, not where there's fluids that are likely to be dropped frequently on the floor, but it should be ways that you can clean it regularly and so on. So the presence of a pathogen doesn't mean it's going to result in infection. There are no known cases, for example, of carpeting that we've been able to find where carpeting itself results in infection. I would think I know of no work that talks about the necessity for vinyl fabric in routine patient areas. We could certainly do a little bit more research and post it in some way, but I would think that it would just require prudence in terms of where there's frequent fluids and being able to clean it on a regular basis. It also depends, in that case, I think, on how you clean the room between patients, and with a good regimen in terminal cleaning, it's called, between patients, I don't think that would be an issue, but we will verify it with our hospital epidemiology friends and respond.
Yeah, and the cleaners that exist now in hospitals, the cleaning chemicals, they're effective at killing pathogens and viruses. The problem is that they're not used effectively. So one of the ways that the environment can help to serve, it can basically serve to shield patients from the poor cleaning habits of the people who are in the facilities. So even if there's a couple of studies that are in there that talk about the increased rates of VRE or MRSA infection if the prior occupant was infected with that pathogen. And that's with regular terminal cleaning. So that's one of the hesitations between using materials like carpet and other fabrics, is that they're more difficult to clean. You can't bleach them. But they also offer potential benefits there with the sound absorption and reducing fatigue from walking on the carpet. So I spent some time looking through the newest FGI guidelines that came out recently, and there's really not a strong stance on whether or not carpets or other fabrics should be used in hospitals.
Let me just jump in here quickly and really to also say that part of our study, but certainly more broadly in the field, is how do you balance risks versus benefits for patients. So the role of a hospital epidemiologist or infection preventionist is to prevent infection, and that it's often a single perspective and an important one, but it needs to be balanced with other kinds of benefits that positive distractions in the form of a fountain or other kinds of positive distractions, or sound reduction in a carpet, and so on, privacy that a curtain can provide. So it is this discussion, and I don't believe there are outbreaks associated with many of those things, but it really emphasizes the point of bringing the infection preventionist into the discussion about benefits and risks of all options, as well as the benefit to patients. And so that's a difficult and complicated question. And I should say that over the time that we're involved with this study, our hospital epidemiologists moved more towards an understanding of the benefits that evidence-based design features bring to patients. So I think that's one of the broad lessons. So Peter, back to you.
I'll actually skip a couple. To a discussion we had the other day when you were describing this gold standard in your evaluation. The idea of, and you brought this up a second ago when you said that not all pathogen existence on a surface necessitates an infection. But was important to the group, it seemed, to evaluate studies in terms of preventing infections versus reducing the risk of infections. And when I went through a lot of the articles, 200 or so articles, you discuss endpoint, with the endpoint being infection reduction versus reduction in environmental contamination, or hand hygiene, and other aspects. And there aren't all that many where could actually show a reduction in infection. Maybe you can talk about this a little more in terms of were your goals achieved and how was that resolved among your group?
Yeah, so most of the literature, or a lot of the articles can demonstrate that a certain intervention or strategy or material can reduce the presence of a pathogen. There's also research that shows that the reduction in the presence of a pathogen can decrease infection risk. So what there's not are studies that show that a specific intervention led to a reduction in pathogens, which also led to decreased infection rates. It's really difficult to set up a nice control trial that way, to say that we're going to put a certain intervention in this unit or this hospital, and we're not going to change anything over here, and everything else is going to stay exactly the same for the entire duration that we're testing out this intervention. So it's really difficult to make that clear connection from intervention to reduced infection.
Absolutely. So I think that, Peter, you're absolutely right, which is that for example, Jay and Jesse, Dr. Steinberg, and Dr. Jacob, for them, the gold standard is to say that by doing a design intervention, actual infection will be prevented. This is a difficult problem in part for some of the ethical reasons that Megan just suggested. We can't do a controlled study. It's in part driven, though, by the nature of the research literature, because many of the research studies that are available are really ways to deal with outbreaks. So there's an outbreak of SARS or MRSA or something, and that then by doing an intervention, by heating the pipes, you can get rid of Legionella, Legionnaire's disease, but that makes the kind of logic that we all want much more difficult because the infection already is there, if that makes sense. So it's a difficult situation, but I think that short of that, what we are all looking for is to find ways at least to limit the presence of pathogens on surfaces in a way that would logically lead to reduced infection, this chain of infection kind of argument, and that then to look for some opportunities, and there are a few now. Even since then, there's at least one study which shows that copper high-touch surfaces might reduce infection. That would be great. We'll see if that works under long-term use. So I think that there's real opportunities, but you've pointed out the great difficulty of the field, which is that on one hand, we want to do this endpoint and we have difficulty.
So was there a consensus among the group that, for lack of better evidence yet, a reasonable approach might be to implement designs and procedures that can reduce environmental contamination, and we just need more research to see what the endpoint will be?
So let me say a few things. One is that I think that the field of hospital epidemiology more generally is coming to accept the importance of design. And that, for example, the national conference this last year, for the first time in its history, ICHE had a track on the built environment. So I think that was so in general, the field is really accepting it. Within our group, I think that there was a strong feeling by the hospital epidemiologists and others that built environment mattered. That ranged from ARC at the top, and this issue has an introduction from Carolyn Clancy, who was then the director of ARC, pointing to the importance of the built environment. So the good news for those of us on the phone who are involved with the built environment is that that is now being accepted by many in the hospital epidemiology community, and that it's particularly, I think, driven by the fact that there is a sense that that they've gone a long way in dealing with other kinds of infections. For example, in dealing with infections that come from central lines or ventilators, but they haven't yet dealt with the built environment as a way of reducing infection. So I think in a positive sense, people are turning to the built environment as an additional tool.
And we have some good questions that are coming in right now for Pamela, who asked for solutions for cleaning fabrics and vinyl, other materials, since cleaning chemicals can damage the integrity of the material. And there are some other technologies that there's pretty strong evidence that supports their efficacy. Ultraviolet germicidal irradiation, for example, hydrogen peroxide vapors, that can be effective at killing pathogens. The limitations of that are that people have to leave the room while it's being cleaned or while the technology is in use. And we also don't know what the long-term impact on the materials are going to be with repeated exposure to UBGI or HPV. And they're also looking at other possibilities to incorporate antimicrobial materials into fabrics or curtains and things like that, such as copper impregnated materials, which their preliminary tests are showing that's effective, but we don't know how long it stands the test. How many washes can it endure?
Can I pick up William's question?
Sure.
Okay, so we had a great question from William where he asks that, or states that the group at his hospital will not allow any water features. How can they be effectively controlled not to prevent or promote infection? So what I should say is a couple of things. One is that the 2014 guidelines, I think, don't allow water features in patient areas in new hospitals, as I read it. Having said that, I think that we've at least only been able to find, of the thousands of hospitals, only 3 cases where there was actual infection that came from a water feature, and at least 2 of them were poorly maintained fountains where warm water stagnated and the spray infected people became infected with Legionella who passed by the fountain. So I'm convinced that that water features that are well maintained and well designed won't result in infection. However, that's a hotly debated topic, I should say, and I would think that for existing water features, making sure that the water moves, is not too warm, that spray is controlled would be prudent. I think for new features, just because of the concern that people have with this topic, is a design opportunity for our field to identify the positive aspects of water features, the restorative notion of having water moving, sound, and so on, but maybe without creating spray that possibly could result in infection. And infection in this case is most typically thought of as Legionella, Legionnaire's disease.
How systems like water systems are maintained, is that much different than how hospital cleaning is maintained? And was there a discussion about what can be done to make sure all systems, whether or not it's cleaning or use of technology we have, water system, how it gets better maintained in the proper way?
Yeah, so with water, we kind of divided into reactive and proactive strategies. So the first thing, safe plumbing practices. It's ensuring that all of the water remains a safe temperature, the water is going to be treated from the cities anyway, so just making sure that there are adequate levels of chlorination in the water. There are other strategies for decontaminating water. Ultraviolet germicidal radiation, again, is effective with water treatment, and so is copper-silver ionization. The challenge with those is that it's pretty costly to install them, and it's hard to quantify the value of something that doesn't occur. So it's difficult if you put in UVGI or copper-silver ionization and you never have an outbreak of Legionella. Well, that's great, but it's hard to say how much that costs. That's one of the challenges in working something like that into the construction budget. But there's also a lot of things to do if you think about the outlets of water, designing sinks safely so that they're deep enough to reduce splashing, that faucets don't pour the water directly onto the sink trap, which again can splash up the water. So it kind of depends on where the location is. There are some that have consistent challenges with contaminated water. Other places just really don't have that problem. But it's important from the onset of building a new facility that you remove things like dead ends and things like that, which can potentially harbor bacteria.
Peter, I wanted to address a couple other questions unless you want to move us along. Our screen is lighting up with all these great questions, and I wanted to touch them, but I need your guidance. Do you want to?
Go ahead. There are actually two questions relating to cost, one from Laura and one from Eileen, if you see either of those on the screen.
Sure. Let me talk about, well, let me start with a great question from Phyllis, which it seems like we address HAI reactively. What about taking more proactive measures? And so what I should say is that our good friend and colleague Roger Ulrich frequently talks about how HAI is handled in places like Scandinavia, where he now lives, and that in that case, what they have a much lower HAI rate than they do in the United States, and of the HAIs, many fewer of them are antibiotic resistant. They do that in a variety of ways by taking HAI as a public health problem, and that first of all, as you enter the hospital, your temperature and other things are measured, and other risk factors, and if you walk through a portal and have an elevated temperature, you would probably not be allowed in the hospital or be pulled aside for observation. Roger at least claims that if you come from the U.S., that's automatically a risk factor because you're seen as potentially carrying MRSA or other kinds of antibiotic-resistant viruses. But so I think that there is the point here is that the real answer to this question is not by solving it in the hospital, but by dealing with it at the perimeter of the hospital, but even more going into the community and getting rid of MRSA the way people in Sweden and others do. That's the real solution to it. But for this study, we're talking in a narrower sense. I think to address Laura's question and Eileen's question, which are really about what's next here in this work, I think that clearly what we need to do is find additional funding and support to balance these issues, because I would say the most important, there's many aspects of what we found is that the built environment can directly control colonization infection and can change behavior, but what we need is research that is convincing to decision makers, and we need to reach out to people like the Center for Medicare and Medicaid Services, Innovation Center, and so on, to fund this kind of work. And that what ARC has done over the years is have supported many of these literature reviews like this, and what I'm hoping is that they will continue to support this kind of work so that designers can go online and find this, because it all becomes in the public domain and available.
And one of the rationale behind having a multidisciplinary team, and we did expert interviews with people in all different disciplines, is so that it doesn't just fall on the shoulders of the designers or of the architects or of the infection control doctors. It's raising the awareness that we all need to work together to come up with a solution to make our hospitals safer. And so that's why we're trying to get this out and talk about it, to let people know that it's everyone's responsibility. So what can we all do about it? That it's not an option not to support research on how to make our hospitals safer. We have to do it.
And let me respond to a couple of questions here, to say that part of the way in which we change, part of the designer's role is to design the environment so that the easiest thing to do is also the safest thing to do. By that I mean that it's automatic when you walk in the door to clean your hands, because the hand hygiene opportunity is right in your line of view when you walk in, and it's simply the natural thing to do. It's and that as a cleaner who has a busy day, cleaning the room effectively, where he or she can see where they've cleaned, that they've done a good job, and that we design in a way that is simply the easiest thing to do. That's the way in which designers can help support behavior which is safer. We just have to make very hard-pressed hospital workers' job easier.
And there is increased motivation to figure out solutions on how to make our hospitals safer from a financial perspective. Reimbursement rates are declining, whereas costs of doing business are increasing, and there's increased attention on patient satisfaction, and now patient satisfaction and safety is tied to reimbursement. So that's one of the reasons that why are we looking all of this now, is that we've done a lot with medication and trying to prevent errors, but that's not enough now. So now we need to look at our next option, which is the built environment.
So some of the things that you just mentioned, more evidence, greater need for multidisciplinary collaboration, expanding the evidence. You have a section here that discusses, takes this then and discusses in terms of design implications, and there are an awful lot of designers on the call now. Do you want to comment how some of the information in this journal can help them going forward?
Sure. So there's that. I think let's sort of walk through maybe each of the modes very quickly. That if we talk about airborne infection, that I think that we can talk about the importance of filtering and of fresh air. That what's happened over the last few years in hospitals is more attention to greater amounts of fresh air and of higher quality filters like HEPA filters. I don't think that there is general evidence that we've been able to find that HEPA filtering an entire hospital, for example, brings benefits, but it may in some situations. The military has chosen to do that in many of their new hospitals. But that I think that in that way it's so better air, I think, is one definition, better filtering, but we aren't convinced, I think, from what we've read, that you have to HEPA filter an entire hospital. We talk about contact. That I think the design implications for us are several. One is that we should design out the necessity to touch things wherever we can. Our colleague, Jay Steinberg, became obsessed with cubicle curtains through this study, and he found hundreds and hundreds of cubicle curtains in his hospital where people many times a day reached the cubicle curtain, moved it across. The cubicle curtains were seldom washed, and he started throughout his hospital finding ways that you could provide privacy without using curtains, using glass that could be darkened or would have shades in it. So I think that designers can design things which, wherever possible, reduce the need to touch. If you have to touch, find ways to make those surfaces easily cleanable, find joints, reduce joints, and so on. Use materials that are easily cleanable, and I think that additional terminal cleaning opportunities like hydrogen peroxide vapor or UVGI. We were in a hospital last week that has a little R2D2-like device that you roll into the room. Takes 5 minutes after a patient leaves. It cleans all surfaces within line of sight of the R2D2 device, the UVGI device, and seem to do from their tests a very good job. So that's a contact issue, and I think design issues around waterborne are really about maintenance and cleaning of the water system, a lot to do with how you design sinks and things which create sprays, including toilets. Other design features that you...
I think that I've already mentioned several of the strategies with water, but I think one of our goals with this article, with these publications, was that this can serve as a resource for a lot of you who don't have the budget or the financial support to do an in-depth lit review like this, that you can go to it, and we've already assembled what we feel is the strongest evidence and summarized it for you. And we've collected the different regulations and guidelines from the FGI and CDC and combined it with our, sorry, my screen just went off. You talk.
Okay, so, okay, we're back. Okay. Sorry.
So we've assembled it all in our guidelines and interventions table. So it's easier for you to know where you need to go, where do you need to find these answers. And so we hope that we're successful at providing you with the resources that you need.
Great. You touched base on the air and the water, and I think the issue does a very good job outlining in spreadsheet format all the different areas. Could you touch base on contact, because your group seemed to indicate that you thought that about 90%, 80 to 90% of infection transmission is coming through contact as opposed to air and water?
Sure. So just to briefly summarize, I think that with contact, it is, again, I think the principles of our design the rooms and the settings so that you can do things without touching them, which includes having potentially voice control rather than keyboards, which might mean if you can find the right faucets, having faucets which can be controlled using infrared rather than touching them. So finding every opportunity you can to reduce contact, having that there is some emerging evidence that having copper impregnated materials helps, and that will be proven in terms of things like multiple washing, so that's contact. That having copper surfaces may work well if it's proven out that will work in clinical settings with multiple washings. Also with contact, there are other issues I think they're important, like having lighting, having one option of the lighting of surfaces be oblique, i.e. not straight down, so that people who clean it can see if there's still dirt or residue on the surface and clean it off. So it is really, I think with contact, it is finding ways so that you don't touch it. If you do touch it, have surfaces which are cleanable or antimicrobial, and then finding better cleaning for surfaces like this UV ultraviolet device.
Eileen asked a question about including manufacturers representatives who are creating these objects that are touching. in the discussion.
Absolutely, and I think that that's a critical part of the discussion and something that the Center for Health Design is doing and can continue to do, which is that, and not surprisingly, for example, even in our study, we found that the manufacturers don't always talk to each other. So the people who do the UVGI don't necessarily talk to the people who develop the head walls, and therefore it's not always clear whether the head wall material or the bed material is impacted by a cleaning methodology. So I think that there's a great opportunity, and they're very interested, of course, in this discussion, but it needs leadership of people like the center to make this happen.
Yeah, and I think as we talk about this more, we're increasingly approached by manufacturers and industry who are interested in an infection, and they do want to test their products. They want to come out with safer and understand how their products can prevent or allow transmission. So I think that's still growing. And
some of the great work being done is like the work that that Clemson has done with DuPont, for example, in their Patient Room 2020, I think is terrific. So I think there's lots of good work starting with manufacturers and lots of options there.
There are lots of good questions.
I'm being told that we should start winding down. I'm wondering whether or not you just want to take a minute or so to summarize some of the successes, pass forward.
Sure. Let me start, and then you can jump in, which is, what's that? No, we're almost out of time. I heard yesterday that Bill Gates in a webinar saying that he was an impatient optimist. And I'm no Bill Gates, but I'm certainly impatient and an optimist. We've seen the infection rate in hospitals go down dramatically in the last 10 years. We've seen now that design is increasingly seen as a tool for reducing this, and we now see the science growing. So I think this is an important moment for us to work together with hospital epidemiologists as designers to help them understand the importance of the hospital design for the multiple advantages it brings patients and staff, and understand how we can balance all of these needs based on science. And I think we can use studies like we've done here to bring not only to designers but to the epidemiologists, because that field, like any others, operates on partial knowledge. And if we can show them that there is, in fact, maybe no danger from carpeting or even from fountains, I think it can help the discussion move along. It's been a great opportunity. I want to thank the center and ARC for this support. This is a work that we continue to work in, and we invite all of you to email us if you have additional questions. Maybe email Megan, and we're happy to answer. Megan?
I think you much summed it up.
Okay.
Thank you, too. I'd like to encourage everybody who hasn't read through the issues to do so. Mike, you want to take over here?
Sure. And thank you for setting such interactive, informative conversation. One final reminder that if you'd like to earn continuing education credits for this session, download the form found in the media library. For credit from the AIA, you need to purchase the CEU management fee, complete the CEU verification form and quiz, and email it to Shannon Reckline. This event is brought to you by the Center for Health Design's Research Coalition and the EGAC program, Evidence-Based Design Accreditation and Certification. And special thanks to the Herd Journal for providing free access to the articles we typically review. If you have not already done so, we recommend subscribing to Herd. Your feedback is important to us. Please take a moment to complete a quick survey at the link at the bottom of this slide. This concludes our event. Thank you again for joining us, and have a great day.
Thanks, everyone.
Thank you so much.